Thanks, Mari. I'm Professor Marita McCabe. I'm from Deakin University. I'm not. I've now moved to Swinburne. I was a deacon, but I'm now, I was a deacon for 25 years, wasn't I? I'm at Swinburne University. And what I have been doing over the last 25 years or so is conducting research on the mental health and well-being of older people, both in community and also in residential aged care. And what we are doing currently is working on how to develop a model of care for people in residential aged care that is centred on the needs and wants of the actual residents.
Now, you led into talking about that program with an interesting insight in that people are actually trained in ways that doesn't get implemented. Can you just expand on that?
Good question. When we started off, we thought if we train up staff, most of our work is on staff training. If we train up staff so that they can better recognise and manage depression and also behavioural and psychological problems associated with dementia, if they can recognise those things among people both in community and in residential care, if care staff can do that, then they are more likely to be able to address those problems. And so we had a training program for staff where they could use a brief screening tool to determine whether or not somebody resident had depression, and then put in place management processes. So let's talk about depression first. Put in place management processes. And we found that the program was very effective. It was a 4-session program for senior staff and on-the-floor staff, and yes, their knowledge increased, their self-efficacy, they felt that they could do this, and yet when we determined whether or not they were able to implement this, or they were implementing this, there was no change to the actual implementation of this process. And we thought, what's happening here? Parallel with that and overlapping with that, we also were developing and for staff a training program so that they could better detect and manage behavioural and psychological problems associated with dementia. So a process where they could determine what the causes for these problems were. Was it bright light? Was it pain? Was it routine? Was it that they didn't want to get out of bed? What was it that were causing these problems? And then, so how can we now manage them without using psychotropic medication? Again, we found that their skills increased, their knowledge increased, but they weren't actually implementing it. So we looked at what was actually happening, and we found that it was organisational processes that prevented this from happening. What do I mean by that? I mean that the people who we had trained were not being given permission to actually implement their training. They still had all their showers to do, all of their other duties that they had to do, and they didn't have time to do it. Further, they didn't know the residents well enough to be able to do it, and so because they were doing 10 showers, they didn't get to know those particular residents. And so for both of those reasons, they didn't have the time, they didn't have the relationship with the residents, and they were not empowered to do it. They didn't get permission to do it, that they weren't actually putting it into practice.
And that's led to a program that you're now trialling across Australia.
We are.
Can you name that program and describe it for us?
Yes. It's a program that is funded by the National Health and Medical Research Council, and it's called the Resident at the Centre of Care program. And what it does is it works with the staff at a particular facility to assist them in determining how they can best have the residents' wishes, the residents' wants and needs addressed within residential aged care. And so it is looking at what we found were the major problems with our other training programs, how we can overcome those types of problems. So what do we need to do? We need to, the care staff need to develop a relationship with the resident. They need to communicate with the resident. They need to find out what the resident's needs are. They need to have a relationship such that the resident feels safe to say what types of things they would like to occur. Secondly, the care staff need to feel empowered to do this. They need to feel that they have permission to actually put in place the residents' wishes. And thirdly, there needs to be a change in the way in which the organisation works so that those two things can happen. And so rather than one member of staff doing showers, another member of staff doing transfers from bed out to chairs and back again, another person doing food for the meals for the residents, one member of staff works with a much smaller number of residents across a range of different tasks, so that they can find out what the needs and wants are of the residents, because they develop a relationship with them. They develop a personal understanding with those residents, and so they can tell if even if the resident doesn't say things, they can tell if the resident is off colour today, and maybe we do the shower tomorrow rather than today because they're just not feeling great, or they're just feeling a bit blue. Maybe they need to go out into the main area, or maybe they just need to have a bit of a conversation. So they tune into the residents' needs through that relationship. And we've found that the residents aren't asking for massive changes to their lives. They're asking to have a shower a bit later, or to have dinner a bit later. And so what we're doing is working with the staff members to see, well, what changes need to happen in the facility to ensure that those resident needs are accommodated. What are the barriers? How can we overcome those barriers? How can we get kitchen working a bit later? Do we put meals aside that just need to be microwaved, rather than going, whoosh, you're all going to get fed at 5:30? Rather than doing that, we say, well, these ones will get fed will have their meals at 5:30, but the rest of them, well, they might want at 6 o'clock or at 7 o'clock, and we don't do showers at 5:30. We stagger that, and if you've got a staff member who is working just with a few residents across a range of different tasks, they can accommodate that, and so the staff member feels more empowered because they've got control over the way in which they do their work. The resident feels better because they feel they have a voice, and they feel that they are being treated with dignity and they have purpose in their life. And the organisation functions better because everyone's happier, and it is a more home-like atmosphere that's created.
Now, one of the things that has come up already very much today has been funding for aged care, that it's too low.
Yes.
And also training, skill levels for aged care workers. How much are they factors as barriers in the work that you're doing?
Look, I think there is no doubt that there needs to be more funding for aged care. There is no question at all of that, and I think that the skill level of care staff needs to be addressed. And I think even ratios need to be addressed. So what I'm going to say does not discount those types of things. But we found that bringing this model in meant that the tasks or the roles of staff changed, in that they worked with a smaller number of residents, but the actual staff complement didn't need to be changed. So we found that the number of staff that were currently in the facility did not have to increase in order to put in place this model of care. It was just a change in their roles. It of course was a change in their mindset. It was the way in which they did business, but the actual staff complement didn't change, the costings didn't change. And so we did an economic evaluation. This was across 9 facilities in our pilot work. No difference. We had a group that got the program plus extra support, a group that got the program alone, and a control facility. And we found that other than our training costs, which were of course there, but the actual day-to-day running of the facility did not change across those 3 groups.
Were organisations surprised to learn that?
They were, and we're doing the same thing now. We're rolling it out now across 39 facilities in Victoria, New South Wales, Queensland and the ACT, and we're doing the same economic evaluation. And so we'll see what comes out of that. We'll have the data in for that by the end of this year. We'll have the data in, and then we'll start analysing that. We're doing a 12-month follow-up with it. We've started with all of the facilities. With most of them, we've finished the training program, but now we've got to do the 3-month, 6-month, 12-month follow-up and see whether the model of care remains and also what the costings are. So we'll have that. Sorry. We'll have that information, most of it by the end of this year. But yes, the facilities were very surprised, because this is what a lot of the facilities are saying is a barrier to putting in place this process. But when you think about it, it isn't more staff, it's the way in which they do things that changes. You've still got the same number of things to do, but you just reorient the way in which that's done, so that you can shower somebody and talk with them at the same time. You don't have to just shower them and then think about what you're going to do next. And this is what it is. You can have, if you've got a relationship with someone, you can be doing things and talking with them, and it doesn't necessarily take more time. And so we weren't particularly surprised that the staffing levels didn't change, but the facilities were.
Fantastic. Thank you very much.
Okay, good on you, Mari.